orientation for the Director of Nursing position for Home Care Network. The following information is relevant to the success of the role of the Director of Nursing here at Home Care Network. Please read over the information carefully and make sure that you do learn the following information. In addition to having this on the computer, you should have this information in front of you within a notebook or a tablet. If you have any questions, please make sure that you do contact your administrator. Please make sure that you do know the name of your administrator for your office and the contact numbers and information for your administrator. Now let's go over the office structure. The Director of Nursing, or as the Director of Nursing, you are responsible for the day-to-day operations of your office. Each office has an office manager. The professional relationship between the Director of Nursing and the office manager is significant. You will work with the office manager daily to ensure the success of your office. The office manager is ultimately responsible for the clerical staff within your office. If you have any concerns or questions dealing with clerical staff or issues, you should consult with the office manager and allow them the opportunity to manage and supervise their own staff. The Director of Nursing manages and supervises all clinical staff. This includes office and field. If the office manager has any concerns or questions, this information will be brought to your attention to handle. Each office is set up according to the needs of the individual office. You will be instructed on the layout of your office staff by a designated person. It is the responsibility of the Director of Nursing to learn each of the roles and have knowledge of the significance of each employee that they have in the day-to-day operations of the office. On the chain of command, it is very important to follow the chain of command to ensure the success of Home Care Network. Each agency has an assigned administrator that is responsible for each office within that agency. The executive administrator is the immediate supervisor of the agency administrators and is executive manager for the clinical, training, education, and billing departments. The executive administrator oversees all agencies and is the first in command on clinical decisions for Home Care Network. At any time that you have concerns, questions, or clinical decisions, issues, you must contact your administrator and allow the administrator time to address your concerns. The administrator will address your concerns or your questions, and if the administrator does not have an immediate answer, your concerns will be directed to the executive administrator. Home Care Network asks our staff to be open to change at all times as we continue to make decisions to progress towards the continued success of the company. Welcome to the team. We are happy you are here. Okay, now let's go over the weekly census report. The office manager is responsible for making sure that a census is ran on a daily basis. This information should be discussed in your morning meetings, which we will go over shortly. And it is the office manager's responsibility to make sure that the census report is sent out to the appropriate people for your monthly monitors, and then also to the owner of Home Care Network. Now let's go over your morning meetings. They should be held every morning by 9 a.m. Your office manager or designee will print and make copies of the reports for your meeting. On your information that you have in front of you and also on the screen, make sure that you understand and know the list of reports that are reviewed for each morning meeting, and also you will see below any detailed information on each one of those reports. Please make sure that in your morning meetings you go over all of the information needed. Make sure that any issues or concerns that need to be addressed during the meeting for that particular day are addressed. Make sure that anything that needs to be discussed in order for that day to run smoothly is also discussed. And also your therapy coordinator should be a part of your morning meeting in order to make sure all your therapy needs are met. Your scheduler should be a part of the morning meeting to make sure that they are informing you of any staff that may be out, any issues that they may be having on getting visits or admissions covered. Also, your office manager is a huge part of your morning meeting in making sure that all of the clerical staff who are assigned different tasks are making sure that they do have everything that you need in order for that day to run smoothly, are taken care of. Now let's go over the referral process. If the referral is called into the office by a physician's office, the office nurse, it could be an RN or an LVN, should document the following information: the patient's name, their Medicare number, address, phone number, physician's name and NPI number, a contact person for the patient, special instructions, pertinent information, and other payer sources. Instruct the caller from the physician's office that someone from the intake department will contact them if further information is needed. The office nurse should write a necessity admit order, fill out the intake referral form, and send the information to the intake department, and make sure to CC the intake director, the agency administrator, and executive administrator. If a referral is called into the office by anyone else other than the physician's office or the physician themselves, please make sure to give them the intake department phone number, which is 877-270-2001, and direct them to contact the intake department with further information for the referral to be processed. Referrals are generally received by our intake department. Now, the referral process itself, the information is taken in by the intake department. Any information that they may need, they try to get up front so we don't have to worry about that once the referral comes to the agency side. They do try to obtain H&P, any orders and lab work, any pertinent information that we may need to get that patient admitted. Also, they will let us know if DME has been ordered, and anything else that may be relevant to that patient's admission. If the patient, if the patient remains in an inpatient facility after 48 hours, the intake department will continue to follow up with that facility until the patient is discharged, and then they will go on with the referral process of sending that information over to the agency side. If the referral is a non-admit due to the patient refused or they were unable to locate, then after 48 hours, the intake staff will contact the marketer to see if they may be able to assist us with locating the patient or being able to obtain more information for that patient. If the patient declines, then on the intake side, then they will make that patient a non-admit on their end, and we would never receive that information on the agency side. Now, intake department will send a heads up email to the office, and that heads up email is just giving you just the opportunity to know that you do have a referral coming up, so that you will be able to keep up with knowing who you will need to get out and perform your admissions. Once they do get all of the referral information and have the referral completed, they will send another email letting you know that that patient has been put into Kaiser. Once you receive that email, make sure that you are getting your RN assigned by your scheduler, and the scheduler should notify the RN of the admission the same date that we receive the referral. Please make sure that we do our best to refrain from scheduling admissions just on the day the admission needs to be performed. As soon as we receive those emails from the intake department, we need to make sure that we're going ahead and getting those admissions scheduled as soon as possible, so that your RNs will know up front what their day will be like the following day, and then you will also be able to keep up with what's going on with your staff. Once the scheduler schedules that admission, they will forward that heads up email to that admitting RN with an admission template. The RN, once the admission is performed, should complete the template on the email and send it back to the office, replying to all, so that everyone, including your therapy coordinator, which is very important, receives that admission information, so we know what disciplines are in the home, and knowing that we need to get those particular disciplines out there as soon as we possibly can. Also, they should be included in there just a general summary of why that patient will need home health services. If the patient is not admitted within 48 hours, or if that patient becomes a non-admit on the agency side, please make sure that you do have that admitting nurse to document a communication note all the different attempts that they've tried to contact the patient, any information that they've received from family members, next door neighbors, or anyone they've had any contact with trying to get that patient admitted, so that we will be able to get that information sent to the physician as soon as possible, because the patient does have to be admitted within 48 hours. Even if the patient has requested a specific start of care date, if it is outside of that 48 hours, we do need to notify the physician in a timely manner, and also our intake department. Okay, discharges. All discharges must be approved by the Director of Nursing before any discharge can be performed. The Director of Nursing discusses the discharge with all staff involved in the patient's care and makes an informed decision on discharging patient from services. The Director of Nursing is to ensure that all services and needs of the patient have been met. If a patient on service for teaching and training, please make sure that all teaching goals have been met. During the morning meeting, you want to discuss your discharges and ensure that the patient has been given a 5-day notice, and also the RN has been assigned to perform the discharge visit. Another thing during your morning meetings, you want to make sure when you're reviewing your hospital log that if the patient does have the end of their cert period is coming up and they continue to be in an inpatient facility, you want to ensure that you are getting that 8-day discharge letter sent out to the patient's homes. And if at all possible, you want to avoid discharging from the desk. And if it is necessary, it needs to be the field RN or the last clinician, qualifying clinician, to perform that discharge. That would include an RN, a PT, a OT, or an ST. Your case managers. The RN in the office who is responsible for the coordination of care for the assigned caseload given by the Director of Nursing. The case managers have several responsibilities. The following responsibilities and tasks are required of the case manager. They QA all of your PACs or your different OASs. The 60-day summaries are their responsibility to make sure that they are taken care of, completed by the field RN, by them completing the 486, and then the case manager is responsible for making sure that those are sent to the physician. Your case managers go out as visits are needed. They are required to do chart audits as you assign them. Keep in mind that your chart audits do need to be done by other disciplines also, other than your RN in the office, and you need at least 5 a month. Your case manager notebook, they have periodic ride-alongs or competency check-offs for other clinical staff members. The missed visits are the responsibility of the case manager to make sure that those are printed from Kinzer, and they are given to the clerical staff to fax or mail to the physician. They're responsible for transfers, ensuring the HHRG scores are correct, and they review all communication notes within their particular caseload. And they need to always make sure that those communication notes that are relevant are sent to the physician's office. There are additional responsibilities that are required, including on-call, making sure that supervisory visits are in compliance, making sure that we are showing coordination of care between the doctor's office and the field and the agency office. And they need to make sure that the home folders are top-notch. And they also are responsible for making sure to turn in their notes on a daily basis by the next business day according to our note policy. Also, the skilled nurses notes and the aid notes are responsibility of the case manager. Case managers are asked to be open and change because job tasks and responsibilities may change as we continue to grow. On the clerical staff, their immediate supervisor is the office manager, and the clerical staff includes the office assistant, clinical assistant, anyone in medical records, and the scheduler. Anytime there is a problem with the clerical staff, the problem should be brought to the office manager's attention. On our software, we currently use Kinzer. You will, throughout your orientation, go through the Kinzer orientation on the computer system, and if you have any questions, you can make sure to contact your corporate educator. You can also contact your administrator or any of the clerical staff or other clinical staff in the office that are familiar with Kinzer. Okay, let's go over the tasks. The tasks are chosen by the RN whenever they perform their OASIS visit, whether it's a start of care, resumption of care, or a recertification visit. They use the drop-down templates that are available on their OASIS that we have gone in and entered, and those are set up by the diagnosis or disease processes themselves. Your tasks that are assigned should be relevant to the patient's care. Every discipline in the home should be listed on the plan of care of the 45. The teachings that are relevant to the current episode should be used, and the RN should not choose a teaching for every single diagnosis because it will be impossible to do them all in a 60-day episode. There should be billable skills performed on every nursing visit. The clerical staff will not confirm receipt of the visit without a billable skill. On your M2250, on your OASIS, if anything says yes, that particular item should be made a part of the 45 of the plan of care because that is the basis of that particular OASIS question, is if any of those particular categories such as foot care or fall prevention are included on the plan of care. So if we say yes to any of those particular questions on that on M2250, we have to make sure that it is made a part of the plan of care. And you will see those below. That's your vital signs, which normally that should be marked NA because most physicians do not give us a vital sign ranges for us to use as a part of the plan of care, and we just use our agency best practice ones. Foot care, that's for your diabetics. Your fall prevention interventions, you do have a fall risk assessment that is a part of the OASIS. So if the patient scores any risk for falls, that fall prevention intervention should be used. Your depression intervention task, that should be used anytime that the patient is on an antidepressant, has a diagnosis of depression, or on your PHQ-2 test on the OASIS if they test positive to any of those particular questions. Your pain clause should be used on pretty much all patients because we should be assessing pain on every patient. Your pressure ulcer prevention task, the Braden scale, is a part of all of the OASIS type visits that you will be performing to set up a plan of care. So if that patient does show risk for pressure ulcers, you want to include this particular task. And then to cover your wound care for your moist wound healing, that will be your wound care orders themselves. Now the OASIS, which is the Outcome and Assessment Information System, is a tool that collects accurate and pertinent information regarding the patient, supportive assistance, and the patient's environment. You want to make sure that your nurses do understand the OASIS, all parts of the OASIS, and as a part of general orientation for all nurses that are RNs, they will have to make sure that they do go over and review the OASIS webinar. But it can be completed by qualifying clinical staff only, which is your RNs, your PTs, your OT, your STs. Your OTs for Medicare patients cannot do starter cares. The information must be complete and accurate when it's turned into the office. The case managers or other RNs will review all of the OASIS, and at times when there is a backup of different OASIS that need to be taken care of for billing, you as the director of nursing will have to step in and assist with that. Map out, the OASIS does map out all of the components called M item numbers, and then again make sure that you are taking part in the OASIS training webinar for more details on the OASIS. On the HHRG scores and your equations, your HHRG scores determine your Medicare reimbursement for a 60-day episode according to the OASIS assessment. It is a responsibility of the assessing clinician to perform a complete assessment and document accurately to the patient's needs. Each discipline and frequency must reflect the assessment. The C, F, and S components of the equations make up the reimbursement according to your OASIS assessment. The C are your clinical M questions, the F is your functional M questions, and the S is only related to service, and that is a reflection of how many therapy visits that you are performing. On this, you want to make sure as you go through and you're reviewing your OASIS, and make sure also that your case managers or other RNs that work for you and are reviewing OASIS understand the HHRG score and equations. This information is reviewed in detail in the OASIS orientation part for a separate webinar. On your M2200 for the therapy service, if we're referring one therapy discipline, we use 12 as the number of therapy anticipated visits. If we're referring more than one therapy discipline, we use 14 as our anticipated therapy visits. On the ICD-9 coding, the first 6 diagnoses have the potential to contribute points towards your HHRG score. Medicare or CMS has made several changes with what diagnoses are payers and which are not. Please make sure that you are always referring to your Decision Health coding book in order to assist you with what diagnoses are payers and which ones are not. Also, in the Kinzer system itself, you are able to click on HHRG calculations whenever you are within the OASIS to review it. The RN performing the assessment decides the primary reason for home health. The diagnosis code should provide an updated and accurate picture of the patient's health. The RN will list each diagnosis relevant to receiving home health care. And then an M1024 is only used when a V code is used, and that's allowing collection of payment by inserting the diagnosis code that the V code is replacing. Also, the V code for therapy should only be used when therapy is the only discipline in the home. Let's review the episode equations. You have 4 equations. They are related to early low, early high, late low, and late high. Your early is in reference to the first or second episode, and your late is related to the 3rd or more episodes. Your low and your high are how many therapy visits are going to be performed. Low is considered 0 to 13 therapy visits, and high is considered 14 or more therapy visits. This information is gone over in more detail within the OASIS training webinar. Now, in order for us to have more success with our accuracy on our OASIS, whenever you are reviewing an OASIS, or any of your other RNs are reviewing an OASIS, and also your RNs in the field should always run an OASIS check and the PPS analysis, which is a part of the Kinzer software that we are currently using. The OASIS check will go through the whole entire OASIS and review to make sure that diagnoses are not missing severity codes, or V codes don't have severity codes. Just the basic OASIS guidelines that need to be followed, the OASIS check will review. The PPS analysis goes into more detail. So if you have a diabetic manifestation code and no manifestation listed directly under it, it will pull that information up. Or if you've gone through and you have documented that the patient needs assistance on their ADLs in your M1800 questions, and then you get to your care management question and you say that patient needs no assistance with any of the ADLs or IDLs, it will alert you to those type of mistakes where the information doesn't match. So the PPS analysis goes into more detail. On the 485, or the patient's plan of care, that is developed once the OASIS itself has been reviewed and approved. The reviewing RN will assure accuracy and completeness before submitting that 485 to the assessing RN to make sure that it is signed to send out to the physician. We will go over how to review the OASIS, the different types of OASIS, your admissions, your research, transfers, how those need to be filled out. That will be in a separate webinar, but I do want you to understand that it is a part of your job duties to review OASIS and to also make sure that your staff understands how to review. On the notes due daily by 10 a.m., all paperwork is due to the office the following business day by 10 a.m. That includes nurses' notes, home health aide notes, and any OASIS that have been performed. A designated employee is assigned by the office manager to contact staff if the paperwork is not turned in a timely manner. At this point, we do have implemented a new program for late paperwork where there are late penalties, and the fine depends on the type of visit that was performed. So make sure that you do obtain that information from your administrator. The office manager does have the responsibility of sending that information to the Human Resources Department for payroll. And an employee will be reported to the Director of Nursing if they're uncooperative with the clerical staff when they're contacting them to get their paperwork in. Okay, now let's go over the schedules. Each office has a scheduler, and that scheduler is responsible for making sure to review all of the patient schedules every Monday. We do encourage the staff that by Thursday of each week they should be reviewing their schedule and getting with the scheduler to make sure that any changes that need to be made, they are made or reviewed with the scheduler at that time. The scheduler will let them know if the visits are able to be moved, because sometimes the scheduler has to ensure that we are staying in compliance with supervisory visits or wound care. If the order is for Monday, Wednesday, Friday, and the nurse is trying to schedule a visit on a Thursday, the scheduler will let that nurse know that they are not able to move that visit due to the order being Monday, Wednesday, Friday. As the Director of Nursing, you do have to make sure that your full-time staff are meeting their daily requirements or their requirements for the week. Make sure that you are keeping up with that on a weekly basis and staying in touch with your office manager and scheduler on that. So there are certain activities that we do want to make sure that we are making a part of the schedule so that your nurses will know particular tasks or activities that need to be performed on their visit. So that includes the home health aide supervisory visits within every 14 days. We need to also make sure that the RN is supervising the LVN at every recertification visit, and that includes all LVNs. Medication administration, for example, injections. If we're to administer B12 monthly, or if we're performing Lovenox injections maybe daily for 10 days, that needs to be a part of that schedule. On the insurance patients, we perform skilled nurse evaluation visits. Those are to let us know on the office side if we will need to continue to try to obtain insurance authorization because that patient continues to need service, or if we will be able to go ahead and discharge that patient at the end of their certification period. That is a communication note with a template drop down, and all they have to do is fill in the information, and then we make sure to get that sent to the physician and to our insurance department on the office side. Our wound eval, which includes pictures, any wound care, catheter care, any patient or caregiver requests when the patient may cognitively not be able to be at a visit with the skilled nurse alone because they may not be able to answer all the questions, and a daughter requests that she be a part of the visit and you call her first. Things like that will be listed on the visits. The research we need to make sure are scheduled within the last 5 days of the certification period. And then just any other information that's pertinent to that patient's care for that particular visit that any of the staff need to be made aware of. We do put this information on the yellow sticky in Kinzer for that note or for that particular visit. Your monthly monitors are due by the 3rd of every month. That information is sent or submitted to our QA director, and the particular information that you need to get to the QA director, those reports will be reviewed with you by your administrator. And you want to make sure that you are reviewing your monthly monitor instructions. For your different logs for your monthly monitors that you do have to submit to the QA department each month, your referral or admissions, those are received or given to you by your office manager. Your discharge report, you obtain that from your office manager because your office manager is responsible for your census and your discharges, getting that information to you. Your infection control, that is usually kept by your case manager. You want to make sure that you are obtaining that information for your monthly monitors. Also, your occurrence reports. Your case manager should be getting that information to you on a monthly basis. On your death log, same thing. Any deaths of patients, those should be recorded and given to you by your case manager. Medication administration, if we have any medication errors. Your hospital log is also another responsibility of the clerical staff. That is something that they should be printing on a daily basis, but then for your monthly monitors, they should give you a hospital log for the entire month that you are reporting that information. Also, please make sure to understand and know that your hospital log, your RN or your LVN nurse in the office should be calling the hospitals and inpatient facilities on a daily basis in order to keep up if the patients have been discharged from inpatient facilities. On the complaints, all complaints are reported to the Director of Nursing or designated person upon the Director of Nursing's absence as soon as possible. Each complaint must be documented by the person receiving the complaint on the patient complaint form. The complaint form must be filled out completely and accurately. All complaints must be investigated upon receiving without delay if at all possible. The Director of Nursing or designated person must follow protocol, which is to take action, follow up, and document. All complaints must be completely resolved within 30 days of the initial receipt of the complaint. Each complaint must be investigated without prejudice, no matter how minute an employee may feel the complaint is. Report all complaints to your administrator and executive administrator in a timely manner. All complaints are kept in a complaint notebook, which should be kept in the Director of Nursing's office. The Director of Nursing should also report all complaints involving abuse, neglect, and exploitation to the administrator immediately, because there are particular protocols that we do have to follow if abuse, neglect, or exploitation is reported. Now, on employee concerns, all employee concerns should be reported to you as the Director of Nursing or someone designated upon your absence. Your employee concerns can include employees' concerns about other employees that are in the patient's home. It can include concerns they have about family members or the patient themselves. This information should be documented, and as the Director of Nursing, you have to make sure that you are taking action and following up to make sure that employee's concerns are addressed. All employee concerns must be reported to the administrator and the executive administrator in a timely manner. This information should be kept in a notebook, and all concerns involving abuse, neglect, and exploitation must be reported to the administrator immediately. That includes abuse, neglect, or exploitation that the employee feels another employee or staff member in the home, or any family members or caregivers that they may feel showing abuse, neglect, or exploitation. On the Medicare qualifiers, We want to make sure that all of our RNs understand the Medicare qualifiers, which ensures that we are in the patient's home performing a skill that Medicare does cover. So for your observation and assessment, you can only max 3 weeks for observation and assessment. So we cannot be in the patient's home for 8, 9 weeks at a time for observation and assessment only. If we are performing observation and assessment, then we have to also make sure that there's another skill that we will be able to continue past that 3 weeks. Or if the patient is having some issues and we're there for observation and assessment, and then we get later down towards the end of the cert period, they start having exacerbations of a disease process or one of their diagnoses, change in medication, and that observation and assessment needs to happen again, then we can write an order for observation and assessment. Your management and evaluation we'll go over in detail right after we go over the Medicare qualifiers. You have your teaching and training. You have administration of medications, and on the administration of medications, that is, for example, injections or IV therapy that does not include the nurse giving a patient oral medication. You have your tube feedings, your nasopharyngeal and tracheostomy care, catheter care, wound care, ostomy care, heat treatments, medical gases, and rehabilitation nursing. Now, those last three we at Home Care Network do not currently perform, but we do want to make sure all of our staff understands what are considered skills and Medicare qualifiers for reimbursement through Medicare for those particular patients. One thing I do want to point out is that lab work is not considered a skill. So we have to make sure that anytime we are performing lab work on a particular skilled nurse visit, that there is an additional qualifying skill that is performed for reimbursement through Medicare. On management and evaluation, or many times you'll hear it called M&E, that is a patient that is currently stable enough not to need observation and assessment, but they continue to need the nurse to oversee unskilled care given to them to prevent exacerbations and rehospitalizations. It can only be performed by an RN because management is not a part of an LVN scope of practice. Also, there can be no other skilled services in the home. For example, if a patient is on management evaluation, they cannot have physical therapy, occupational therapy, or speech therapy in the home, but they can have a home health aide. So only an RN is able to visit patients for M&E. The goals for M&E patients is to prevent exacerbations and rehospitalizations, to minimize complications, and to monitor and evaluate underlying conditions. If you want more details on M&E, please see your nursing reference guide for those details. On your chart audits, we have to make sure that we are performing 5 chart audits a month. And on those 5 chart audits, you want to make sure that you have other disciplines assisting you with those chart audits. For example, you should be assigning at least 1 or 2 of those to different therapists, your LVNs, and your RNs in the field. So chart audits are not just the responsibility of the office nurse, but all disciplines in the field need to be assisting with the chart audits. And then the different disciplines in the field that are performing chart audits should only have to audit the discipline, should only have to audit their own discipline and not other disciplines that are in the home. And those chart audits are to be sent with a summary for your monthly monitors to the QA director on each month. For case conference, this is a list of patients coming up for research. Your office manager is responsible for making sure that those lists are emailed a week prior to the case conference to your field staff so they can come to case conference prepared for the meeting. Case conference is held every week. It's a weekly meeting at your particular office on the day and time of your choosing. Usually each office has a different day and different time because some of our staff do work for different offices to give them an opportunity to be able to attend each case conference. We do want to make sure that each discipline does attend case conference. It is very important because at that time the RN is able to collect information for the 60-day summary or the 486 that we need to make sure we are getting sent off to the physician. On the teaching, we want to make sure that your staff understands that teaching should be relevant to the patient's needs. We want to make sure that we are, at all costs, trying not to have repetitive teaching unless it is documented that it is absolutely necessary for those particular teachings to be repetitive. Each nurse should be using their nursing judgment and their nursing knowledge to choose relevant teaching. Each teaching task should be completed with goals met, and we want to make sure that before we discharge a patient that those goals have been met. And then on every start of care, resumption of care, and recert, we want to make sure that the following are instructed on each one of those each one of those OASIS visits. That's your emergency care plan, your emergency preparedness, and your after hours on call. Okay, so now let's go over the billing. The billing coordinator for each of the offices sends out a billing list on a daily basis. The list should be gone over in your morning meeting to ensure that everyone understands what's on the billing list and what needs to be taken care of. The billing list is reviewed by all staff, clerical and clinical, in the office to ensure that the billing goal is being met on a daily basis. Your office manager or who they designate will make sure that each one of the particular things on the billing list is turned in order for yourself, your case manager, or any of the other RNs are able to review the information and get it completed so that the billing department can go ahead and bill for that day. Now, as a general rule, you will have to ensure that your staff understands that no one leaves until the billing department gives the okay that the billing goal has been met for that day, and that everyone can go ahead and leave from the office for that particular day. On your intake department, only thing I wanted to also point out besides the intake department taking care of our referrals is that they also take call each day. So our after hours is answered by our intake department. So anytime anyone calls after hours, they will receive an answer from someone in the intake department. And if the intake department feels that it is a clinically related issue, then they will call the RN that is on call for the particular office that a patient is in. We want to make sure on agency forms that we're only using agency approved forms, and we try our best to make sure that we are able to put templates in Kinzer in order for us to not have any paper forms, but we have at least a couple of forms that the patient does have to sign that we do have to obtain signature and have to have it on paper. So what we do is to have the nurses have the patient to sign in the home. The nurse will then take a picture and email that picture to the office, and then we will attach that particular picture to the patient's chart so that form will be a part of their records. Again, just a quick note on your non-admits. You want to make sure that anytime a patient has not been admitted to services, that the assessing or the admitting RN that has been assigned to that patient does complete a communication note stating why that patient is a non-admit, all the different communications that they've had with the patient, physician, or anyone else pertinent to that patient, to ensure that we are notifying the physician the reason why the patient is a non-admit. For human resources, all disciplinary documentation and evaluations must be reviewed by the Human Resources Director prior to presenting the staff involved. So you want to make sure anytime that you fill out any evaluations, whether they're 90-day or annual, or anytime that you do any disciplinary action, that does go through the Human Resources Director first for approval, and then when she gives you the okay, you can then present it to the employee that is involved. On your employee alerts, make sure that those are being taken care of. You will receive emails from Human Resources reminding you when evaluations on sites, um, CPR, driver's license, TB tests, any of the information that HR needs, they will send out an alert. And as the director of nursing, you will make sure that each one of those things are taken care of. Now, you can designate to your office manager on your um, for your clerical staff, and then also you can designate to your office manager to assist you in obtaining like copies of CPR, copies of driver's license, that type of thing. The director of nursing is to conduct exit interview on terminations and obtain information from human resources on change of employment status. Your time off requests, those are actually put into the HR software. Um, Anyone that is assigned to you, your employees under you, if they fill out a time off request, you will receive an email from the human resources software system, and then you have to go in and approve that time off request or decline it. For the skilled nurse in services, those will be webinars. We are trying to get to the point to where we have the staff coming into the office less and less. Now that we have fewer offices, some of the staff do have to travel quite a long time, an hour or more, to get to the office. And so if we're pulling them in several times throughout the month for different types of in services that we may need or information we need to get out to them, that gives them less and less time out in the field visiting patients. So anytime that we do have in services or any information we need to get out to the staff, we are trying to have that set up through webinars. Your corporate educator will send out an invitation to you, and then it is your responsibility as the director of nursing to make sure that all of your field staff that are pertinent to that particular in-service does receive those invitations for them to sign up, because we will try to always have several different meeting days and times to give them the opportunity to not miss the information that is needed. For your QA/PI notebook, we want to make sure that we are keeping up with all of our quarterly QA reports that we receive from the QA director, and the QA director will send QA/PI plan of corrections that will need in services. And again, your corporate educator is responsible for making sure that those webinars are conducted. But as the director of nursing, it is your responsibility to make sure that all staff are aware and receive the invitations for those webinars. For your home health aides, those in services, there are 12 mandatory subjects that we do have to cover annually. As the director of nursing, it is your responsibility to make sure that your home health aides do receive all 12 subjects that they are supposed to. You will receive a calendar of the in-services for that year. Now, we are setting up to where we can have all in-services on our website. So all the home health aide would have to do is to log on to the website and be able to complete their in-service and their quiz, and then that will come back to the office in order for us to be able to print out and keep as a part of our home health aide in-service notebook. Also, please note that last year in 2014 it was put in place that home health aides have to have their continuing education hours just like the nurses do. So our human resources department does keep up with that, and when you receive those emails notifying your staff that they need to continue or get their continued education hours in, please make sure to follow up on that, because once it comes up to their expiration date and they have not turned in their continuing education hours, they will be removed from the schedule. Let's go over on call a little bit. I know you may have heard already on the on call during your nursing quick reference section, but just to hit that information one more time, every nurse takes part in the on call rotation except for the director of nursing. Now, every now and then, if you may be short staffed, you may have to jump in and assist, but the director of nursing is not a direct part of the on call rotation. And the frequency of the on call rotation depends on the number of nurses that are working for each office at that particular time. The on-call schedule, you should try to get that out at least 2 months in advance, if at all possible, so that your staff will be able to make arrangements to ensure that they are able to be on call for the week that they need to be. Changes are made according to the staff at the time. Call begins on Friday at 5 p.m., ends the following Friday at 8 a.m., and whoever is on call, that RN, will receive calls from our intake department during our after hours. There's always an RN and an LVN on call together. The LVN will be scheduled to perform any regular skilled nurse visits, so that will free up the RN to be able to do OASIS type visits. So if you have any daily wound care, insulin patients, those type of patients that are daily, every other day, twice a day, your LVN will be scheduled to visit those particular patients. And make sure that you do see the on-call instructions in more detail in your quick nursing reference book. Under policy and procedure, that manual is kept in your office, and you should make sure that it is available to the staff whenever they would like to review it. It contains the policy and procedures adhered by Home Care Network. Healthcare Consult Link mails us our updated policies as changes are made in home health. Make sure that those updated policies are reviewed and that each one of your staff member receives those updated policies. What we're doing is making sure that we are emailing a copy of the new policy to each one of our employees, and you want to make sure that when you send those out, or if you designate that to your office manager to perform for you, you want to make sure that each one of your employees sends back an email stating that they have reviewed and understand the new policies, so that you will be able to keep that as a part of your policy and procedure notebook. On the nursing procedures, you should have a nursing procedural manual that is kept in your office. Again, for the availability of any of your staff that want to review any nursing procedures, it contains all the processes for clinical procedures for the skilled nurse to follow. So if your nurse needs to brush up on her Foley catheter change, or sterile dressing change of an central cath, or any type of clinical procedures for the skilled nursing, you should have that available in your office for them. Also, let me point out too, if any of your nursing staff feel like there is a particular skill that they're not up to date on, or they just haven't performed it in a while, then make sure that you are connecting them with another nurse or your case manager, or even yourself, to be able to get out in the field and be able to get that particular skill down. So whenever you need that nurse to perform that skill, there will not be the excuse of they don't know how or haven't done it in a really long time. You just want to make sure that all of your staff is up to date on all of the skills that we perform here at Home Care Network. Your nursing quick reference is a guide that has been put together for Home Care Network nurses, and it contains all the pertinent information for those nurses to be able to reference back to. On your insurance, here at Home Care Network, we don't do 60-day certification periods on all of our patients. So make sure that you do review your insurance list that you will receive to know which patients are 60-day certification periods and which patients are 30-day certification periods. We do have insurance patients for particular insurance companies that we do 30-day certification periods. You want to make sure your staff understands which patients those are. And you want to also make sure that we are given a 5-day discharge notice. We want to make sure that we are doing that skilled nurse evaluation 2 weeks in, so that we know before that certification ends that that patient will need to continue with home health services for continued authorization, because when we wait until the very last day or the last minute to contact the insurance company, it can sometimes take them up to a week, and a patient may have delay in their care, and we try to avoid that at all costs. On OSHA, Stericycle is the company that we use to keep in compliance with OSHA. Stericycle has scheduled pickup times for each office for the disposal of biohazards. They do have mandatory in-services that it is the Director of Nurses' responsibility to make sure that those are met. Our annual mandatory in-service, it is the Director of Nurses' responsibility to make sure that that is set up with Stericycle. Well, they come out, they perform the infection control, um, TB, hepatitis, all of those mandatory in-services for all the staff, and they will come out to the office and perform an inspection at that time also. So just make sure that you are keeping your Stericycle notebook up to date, and that also you get that scheduled annually. On our wound protocol, our wounds are measured weekly, and we also schedule wound evaluations for the skilled nurses to perform within every 14 days. We want to make sure that they include pictures of the wound whenever they perform the wound evaluation. And we need to make sure that our nurses understand that we need pictures taken on the initial finding of a wound, with these evaluations, on admissions, and also post-hospitalization visits. For the wound eval, they need to make sure that they're documenting. On a communication note, there is a template for the wound eval. They click on the drop down, choose that template, and they fill in the blank. We want to make sure that we're documenting the progress of the decline of the wound, and that we're keeping the physician up to date with what is going on with that wound. Also, you can review the nursing reference notebook for more details on that. Our finance department takes care of our cell phones and any of our other electronic devices, such as the iPad. We want to make sure that anytime we have any questions about cell phones or any other electronic devices, that we are contacting the finance department. Any questions or concerns about payroll should be directed to the office manager, and they will make sure that that information is taken care of. The Director of Nursing is to maintain clinical staff working hours and make sure that we are meeting the required visits for the full-time staff hours. Okay, on the medical supplies, each office has a set budget depending on the census. A designated office employee is responsible for ordering medical supplies and keeping up with the inventory. Now, all of the field staff, as they need medical supplies, there is an email that they should be emailing what supplies are needed, and that designated person in the office will make sure that those office supplies are ordered in a timely manner. Each time any staff member removes supplies from the supply room, a supply form should be completed and given to the employee who handles the supplies. If emergency supplies are needed, it is the responsibility of the Director of Nursing to inform the Executive Administrator to request authorization for an emergency requisition. And we want to make sure that everyone understands that supplies are ordered monthly. But if there is a time when we're running out of something and that the patient needs that particular supply, we will make sure that that is taken care of. Office supplies, same thing. Each office has a set budget on office supplies for paper, toner, folders, those types of things. They are ordered once a month. If an order needs to be placed outside of the normal ordering time, the office manager must inform the executive administrator to request authorization for an emergency requisition. The office manager is responsible for the management of the office supplies. For the office card, there is a designee at each office who is responsible for the management of the office credit card. Each office has a budget on the card. The card is used for coffee, cups, paper towels, toilet paper, etc. Your dress code, please make sure, I know this has been addressed in your nursing reference and it's also addressed with human resources orientation, but just want to go over it again just so you make sure to know that your field staff must wear scrubs. Now they can wear jeans and an HCN shirt with tennis shoes on Fridays, but any other day of the week, they must make sure that they are wearing scrubs, that they're neatly pressed, that they have on closed-toed, comfortable shoes. They should always make sure that they're wearing a name badge whenever they're going into the patient's home. The jewelry should be a minimal, and tattoos and other body piercings should not be visible. On the office staff side, business attire is required. Casual Fridays, you can do HCN shirt and jeans. The shoes just need to have some type of a heel. They just can't be a flat or a ballet type shoe. And open toe is anytime during the year. Everyone should wear their name badges, and tattoos and other body piercings should not be visible in the office. If you have any further questions on dress code, you should go back and review your employee handbook for more details. On emergency preparedness, each director of nursing is the disaster coordinator for your particular assigned office. The office manager is responsible for keeping the emergency preparedness notebook up to date. That should be done at least once a week. The office manager is to print the updated information and give the updated notebook to the director of nursing every Friday. The director of nursing is to alarm staff when an emergency occurs within the office area of service and implement the plan. Make sure that you do see the emergency preparedness plan notebook if you have any further questions. The Professional Advisory Committee, or the PAC Committee, consists of a representative from each discipline that we represent at Home Care Network, and also a community liaison. The committee meets annually with the medical director and reviews new and changed policies, the agency's report card, and the annual agency evaluation. The meeting is conducted by the QA director, administrator, or executive administrator. So you may be asked as the director of nursing to take part in the PAC committee. Your peer review committee. This committee consists of representatives for the LVN and RN. If an LVN is up for review, then the LVN members of the committee take part in the review, and the same for the RN. All directors of nurses are members of the committee, but cannot participate in a review of their own staff. Please make sure that you do see the peer review committee notebook for all details. OASIS validation report. Your OASIS validation reports are ran monthly by the OASIS submitter. This is reviewed by your administrator and your office manager on a weekly basis. Every week as this is printed, you may be asked to make corrections, but it is ultimately the responsibility of the administrator to ensure that any corrections that need to be made are performed. On your STEER, as a home health agency, the government has put it as our responsibility to make sure that all patients are aware of emergency preparedness. And as a part of our program for emergency preparedness, we do ensure that all patients who are EC1s are registered for STEER. This will allow that patient, in case of an emergency and an evacuation is needed, this patient will be registered to where they will come out and assist the patient with evacuation in case of an emergency in their area. On the field orientation, anytime that you have a new employee that works in the field on staff with Home Care Network, you want to make sure that they do have a ride-along with an experienced person within their discipline, whether it's the home health aide, a therapist, an RN, an LVN, to ensure that that particular employee does get enough orientation hours in to where they feel comfortable before becoming independent. Once they do ride out with someone experienced and they are ready for checkoff, it is the responsibility of the director of nursing to ensure that your scheduler and your office manager do get your new employees set up for a skills checkoff for field visits, and make sure that all the needs that employee has are met, including making sure with your nurses that we are getting their skilled nursing bags to them with the necessary basic supplies. And last, for office procedures, all Home Care Network office procedures should be followed at all times. Um, no procedure or process should be changed without the approval of the executive administrator. If you have any questions about office procedures, please make sure that you are contacting your administrator or your executive administrator if your administrator is not available. Just want to keep in mind, please do not change any Home Care Network procedures or processes without prior approval. Okay. If you have any questions after you go over your director of nursing orientation, please make sure that you do contact your administrator. You also have your corporate educator who's available if you have any questions, and HCN welcomes you aboard. Thank you.